Now let us look at the third ABG report where the pH is 7.54, the PaCO2 is 25 and the bicarb is 21. I hope by now you know what steps we have to take so we can go a little faster. Step 1 was to look at the pH, and if the pH is above 7.45 it is alkalosis. In this case the pH is 7.54, which is much higher than 7.45, so step 1 diagnosis is there is alkalosis. Because the pH is above 7.45 there is alkalosis. So coming back to writing the diagnosis, we write here as alkalosis on the right side, and as I told you earlier we will write the next diagnosis here and the next diagnosis here on the left of the word alkalosis. So we will be writing from right to the left. Now with the increased pH with the alkalosis, the PaCO2 is decreased, and this fits the definition of respiratory alkalosis. So step 2 was we decided the alkalosis is respiratory. As we saw, the normal PaCO2 is 35 to 45 and any PaCO2 below 35 is low. In this case the PaCO2 was 25, so it is low, and that is why step 2 shows that the alkalosis is respiratory. Now let's go to step 3. Now the patient's pH is 7.54, so it is 0.14 above the mean. Patient's PaCO2 is 25, the normal mean being 40, so the PaCO2 is decreased by 15. So let's do the math now. For 15 millimeter change in PaCO2, the pH has increased by 0.14. So for 10 millimeter change in PaCO2, it will change by 0.09. The easy way to do it is 2/3 of 0.14 is 0.09. Suppose it was 0.15, the 2/3 will be 0.10, right? Because it is 0.14, it is 0.09. Easy. You can directly also divide 0.14 by 15 and then you can get this number. So here for 10 millimeter change in PaCO2, the pH has changed by 0.09, so it goes in favor of acute nature of the respiratory alkalosis. Now let's go to the next slide. Here we confirm what we had seen. We have already calculated the PaCO2 value. Now look at the bicarb. It is 21, the normal mean is 25, so the bicarb has changed or decreased by 4 from the mean. So for 15 millimeter decrease in PaCO2, the bicarb has decreased by 4. So for 10 millimeter it will be 2/3 of the 4. That will be half of 4 is 2. 75%, that is 50% is 2, 75% is 3, so 66%, that is 2/3 is 2.7. Or you can simply do 4 multiplied by 2 by 3, that is 8 by 3, and that is like little less than 9. Again, we don't have to go into the exact 3 numbers after the decimal, no. But as long as we can see that the change in bicarb is around 3 for 10 millimeter change in PaCO2 with respiratory alkalosis, it is acute respiratory alkalosis. Now let's look at the next report. The pH here is 7.46, the PaCO2 is 20 and the bicarb is 15. We go to step 1 and we look at the pH. We know if the pH is above 7.45, there is alkalosis. So this patient has alkalosis, and again, as I said earlier, we start writing the diagnosis from the right to the left. So we write the diagnosis of alkalosis first. Step 2, we look at the PaCO2 in relation to alkalosis. The PaCO2 here is decreased along with alkalosis, so this alkalosis is respiratory. So we write the diagnosis of respiratory before the alkalosis, so it becomes respiratory alkalosis. So easy. We have already completed 2/3 of the diagnosis for this patient. Next step, step 3, we look for change in pH for 10 millimeter change in PaCO2. Here the PaCO2 is 20, the normal mean is 40, so the PaCO2 has fallen by 20. The pH is 7.46 in this patient, the normal mean is 7.40, so the change from mean is 0.06. Let's wear our math hat. For 20 millimeter decrease in PaCO2, the pH has increased by 0.06. So for 10 millimeter decrease in PaCO2, it has increased by 0.03, and that fits the diagnosis of chronic nature of the respiratory alkalosis. So it is chronic respiratory alkalosis, and we write the term chronic before the term respiratory, and it becomes chronic respiratory alkalosis. And as we saw earlier, we wrote the diagnosis from right to the left. First we decided it is alkalosis, then we decided it is respiratory, and then we decided it is chronic. Now let's look at what's going on with the bicarb. The PaCO2 we have already seen. The bicarb is 15 in this patient and the normal mean is 25, so the bicarb has decreased by 10. So for 20 millimeter decrease in PaCO2, the bicarb has decreased by 10. So for 10 millimeter decrease in PaCO2, the bicarb has decreased by 5, and this again meets the criteria for pure chronic respiratory alkalosis, and this confirms that the blood gas report is correct. So simple. 4 steps. First step, acidosis or alkalosis based on pH. Second step, PaCO2 in relation to acidosis or alkalosis. Third step, change in pH for 10 millimeter change in PaCO2. And the fourth step, change in bicarb for 10 millimeter change in PaCO2. Chronic respiratory alkalosis is not very common in clinical practice. Beware giving this diagnosis to a patient, and before you decide that the patient has chronic respiratory alkalosis, make sure you have ruled out other disorders, you have ruled out mixed disorders, and you have ensured that the given blood gas test report is correct. And to do that, you use hydrogen ion formula. You can see more details on this formula and how hydrogen ion corresponds to the pH in the book. Let's look at the causes of respiratory alkalosis. Just on the same model that we saw the causes of respiratory acidosis, we will see what are the causes of respiratory alkalosis. You can refer to the book, to the Essentials of ABG part, where these things are explained much more in detail. The impulses generated in the brain and brainstem can be affected by encephalitis, anxiety, painful arterial puncture, and in pregnancy, because in pregnancy the increased progesterone can act on the brainstem and reset the cycle, excite or stimulate the cycle. However, much more important causes of respiratory alkalosis, and I want you to focus on these ones because they are so important and they are missed so many times. Do not ascribe any low PaCO2 to anxiety or painful arterial stick till you have excluded these other causes, till you have made sure that there is no chance that these other causes may be responsible for that low PaCO2. And what are those causes that cause low PaCO2? They are pulmonary embolism. This diagnosis is missed so many times that I have put it in block letters, I have underlined it. Please, 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 any patient with low PaCO2, immediately look at A gradient. If the patient is in a group that is prone to get pulmonary embolism, young female, patient who had fracture of long bones, patient who has been bedridden, patient who is very sick, patient who is on oral contraceptives, patient who has been smoker, patient who may have a carcinoma somewhere, always make sure that pulmonary embolism is not causing that low PaCO2. Same way in asthma, it's very important that what happens that in these conditions, because there is some hypoxia, the body starts breathing more, hyperventilating to get enough oxygen that is needed by the body, and as a result more carbon dioxide is washed out of the body, causing a fall in PaCO2. So if an asthmatic patient had a slightly decreased PaCO2 and now the PaCO2 is coming towards normal, be careful. This patient is either recovering from asthma or the patient is going towards acute respiratory failure, and that is why the clinical exam is so important. You have to see the patient. How is the patient doing? The third common important cause of low PaCO2 is pneumonia, and again, because there is hypoxia, the body compensates by ventilating more to get enough oxygen, and as a byproduct the PaCO2 is decreased. So do not take low PaCO2 lightly. This happens all the time, that when the PaCO2 is slightly low, we ascribe to everything like anxiety, painful arterial puncture, but that's fine. It does happen sometimes, but do not miss the important causes, because missing a painful arterial puncture or anxiety will not kill the patient. Missing pulmonary embolism, asthma, pneumonia will kill the patient. So be careful. And the last is, of course, ventilator malfunction. So if the patient is ventilating through a ventilator and the ventilator is set, say, at a very fast breathing rate, 20 or so, 16, 18, or the tidal volume is big, then the patient will be ventilating much more air in and out of the lungs, causing a decrease in PaCO2 because more carbon dioxide will be washed out of the system. Again, here you saw causes, most of them cause acute respiratory alkalosis.